Good morning, I'm Kate Kearney from University of Washington. I'm going to be talking about the importance of vessel preparation in diffuse disease. Here are my disclosures. So, of course, initially we'll get some talks today about evaluating diffuse disease, but I hope to briefly convince you that image guidance and invasive physiology are our friends with this type of patient population. Also to emphasize why adequate vessel preparation is so important to reduce risk factors for target lesion failure in diffuse disease and develop a plan for adequate vessel prep in these lesions. So why is vessel prep especially important in diffuse disease? Well, of course, we know that there's a number of patient factors that put them at risk for recurrent events, but those also overlay with PCI and technical risk factors for in-stent restenosis, which are modifiable by us during the procedure. We know that any underachievement in our luminal area gained has additive resistance built up over as we increase the length of the treated area. In addition to that, that can be worsened by ambiguous landing zones and any untreated inflow or outflow disease that we didn't fail to identify. All those things are important, of course. In addition to that, we're just more likely to be dealing with side branch disease and a higher degree of plaque burden or diffuse nature of the disease, which can emphasize the importance of vessel prep to both reduce plaque shift and may affect our treatment strategy, or pre-treating those side branches to avoid a two-stent strategy in some cases. So we know that stunt length and calcification predict target lesion failure. This has been seen in a few different registries. Here's one data set from Ziadoli and others in a recent look from last year, where they found that total stent length was actually the only predictor at 30 days, whereas we had others, including moderate to severe calcification, the post-procedural diameter looking 3 days to a year, with reference vessel diameter being the technical factor observed at 5 years of TLF. This overlays, of course, with clinical factors like smoking and diabetes and other patient-relevant issues that overlay with high plaque burden and diffuse calcific disease, which then have implications and have been shown to see higher rates of higher degree of complexity in terms of the PCI that's required, both with bifurcation disease and CTOs. Those patients then have lower rates of complete revasc. If we want Syntax 2 style outcomes, however, we have to do the work that they put in. So up front, they were using new generation drug-eluting stents. In this case, that was the biopolymer degradable everolimus-eluting synergy drug-eluting stent, but importantly, they also did physiology-based revasc. They used image guidance to optimize their stent results and used contemporary CTO techniques to improve their success rate. On the background of guideline-directed medical therapy and very low LDL, we saw a vast improvement in both MACE and repeat revascularization. But if we want to achieve those results, we have to do the work that they put in as well. So it all starts with evaluating diffuse disease. I think the more we learn, the more we know angiography is insufficient. So to help us decide what to treat, invasive physiology, and particularly with pullback in these long segments of disease, can really help us identify the target. In many of those segments, it visually may not appear very significant, but that long calcified lesion might be more physiologically relevant to the patient than something that's juicy and easy to pick off in 10 minutes and get out of the lab. Once we've decided we're treating, really intravascular imaging is necessary to help guide a lot of the decision making. Sometimes this is with atherectomy, but with always it's other vessel preparation needs in terms of sizing for our balloons and our stents, where to land them, and to verify our stent integrity in the end. I would argue that vessel preparation is the product really of our imaging and physiologic assessment. Stenting is just the icing on top to make it look pretty at the end, but the bulk of the work we do in gating improvement in the physiology of the patient comes from this other investments that we do up front. Here's just a case of a woman who's come back a number of times for angiogram due to angina. We've seen this occluded RCA repeatedly. We've also repeatedly assessed this circ lesion because I think that looks relatively easy to treat. I actually repeated the IFR because I didn't believe how normal it was, but again, it's 1. So by dropping a stent there, we make ourselves feel better. We don't do anything for her. She's now coming back for RCA, CTO, PCI after discussing that further. So we know that intravascular imaging helps us determine our vessel prep needs once we get in there. Sometimes that's decision-making with regards to atherectomy. There are some algorithms to help with that. We're gonna have a good talk related to a lot of imaging concerns. Sometimes this also helps us guide what type of atherectomy we might use, many times in overlapping fashion. I would just argue that in diffuse disease and tight leading edges, rotational atherectomy is really expedient and helps us get through that in a more efficient fashion for the patient and hopefully reduce the ischemic burden as well. In this case, is a 72-year-old gentleman with class 3 angina. He can't go elk hunting, which bothers him significantly. Not really pertinent to the case, we end up going retrograde. Once we're externalized though, we flip out for a rotofloppy wire because I know that this proximal disease is going to need that leading edge atherectomy. We're going to use a small burr because there's a short segment where we're subintimal. But if you recall our setup shot, really the rest of it, we don't know what decision making needs to happen or what further vessel preparation is required. So IVUS helped us identify exactly where the stent ended, where I could be more aggressive in particular, helps me see where it might be subintimal, so I'm a little bit less aggressive, free dilation. And we, at low pressure with the 401C, see that we've got good expansion number of areas. So when we finally drop our 3 overlapping 4mm stents, there's no surprise that they look fine on angiography, and we know that they're in a good landing zone. So with angio and with our IVUS, and we're confident that we have a good stent result for the patient and hopefully a good long-term outcome. I think these strategies are nicely outlined by Demare and others from last year in a review, looking at dealing with high calcium content lesions and diffuse disease. What we gain from better vessel preparation, I would argue, is that we can eliminate gross stent under expansion. There should be no surprises, and there's really no reason for patients to have acute in-stent thrombosis as a result of us having stent unexpanded stent. We can improve our long-term outcomes in terms of apposition and decreasing plaque shift and branch compromise. And we can improve our efficiency because we're anticipating issues rather than reacting to them. And in doing so, hopefully we can at least reduce unnecessary complications. Of course, complications are part of our job, but by decreasing our guesswork and doing the treatments that are needed, we can hopefully contain those. Using good technique can minimize complications for our patients as much as possible. So in summary, physiology-based image-guided PCI is known to improve outcomes, and I would argue that it also improves our efficiency, especially with good practice, to help us decide what's necessary for vessel preparation, rather than helping us get away with what we can get in today, but not necessarily having a good result for the patient, and sometimes really leading to a struggle in terms of getting a good result even that day in the lab. Finally, vessel preparation and stent optimization are particularly important in long segments of disease because of risk factors for stent failure. And it's really incumbent upon us, particularly in these cases, to gain as much luminal area as possible, get the patient a good result. With that, thank you very much, and look forward to hearing the rest of the presentations.